Hague Practice Liaison Officer for Knots LMC. Today we are joined on the call. We've got two parts. We're going to be joined by Paul Miles and a colleague from the sexual health team at Notts County Council, where we're going to be talking about the LARC specification and also the NHS health check specifications that have recently come out. Part two will go into Sudhakar Shind and Dr. Kelvin Lim, who will be talking about IMS and vaccinations, following a couple of feedback sessions with practice managers over the last couple of months. And then we'll go into a quick discussion. In fact, Lucy will take control at the end of the session as I nip off, and then we'll lead towards the end of the session and stop recording. So without further ado, I will introduce Paul. I can't see you with your camera on.
Sorry, Stuart. I'm just moving. It wasn't very good, so somewhere else to sit in my house. It's got a bit of a better signal. Can you hear me? Okay.
Oh, we can hear you. Yeah. If you can get on the roof. No, don't do that. Let me know when you're ready.
Just give me a second.
Yeah, of course.
Try and share our slides. Have they come through?
Not as yet. If you wanted, you're more than welcome to email it to me, then I can share if that would help.
I was hoping it would share on the screen.
Okay. There's a few colleagues still joining us, so.
Right, where is it? There we go. Right, has that worked now?
Okay, yes, this is coming up.
Brilliant.
And yes, I have it.
Okay, lovely. Thank you ever so much for the opportunity to come and speak to you all today. So as Stuart said, my name's Paul Miles. I'm one of the senior public health and commissioning managers within the public health team at Nottinghamshire County Council. Matt, did you just want to quickly unmute yourself and say hello?
Yep, my name is Matthew Osborne, Public Health Commission Manager, also at Notts County Council, and work on the sexual health agenda. Thanks.
Brilliant. So yeah, obviously really pleased to be here today. There's lots of work going on around the recommissioning of NHS health checks and the long-acting reversible contraception or LARC services at the moment, and the deadline for the initial round of submissions is fast approaching us now. Hopefully this is not the first time people are hearing about this, but we thought alongside all of the other engagement that we've been doing, it'd be really good to come along and say hello today and just check people are getting on okay with things. So obviously, as we're both from the county council, we're obviously talking about the county LARC services and NHS health check services. So apologies for those people that are on the call from city GP practices, but hopefully this will be useful to understand what's going on in the county anyway. Just to go through a few key points, I suppose, for today and some next steps between us. So we're recommissioning the NHS health checks and LARC services. These will start potentially from April this year onwards. We weren't necessarily planning to recommission either of these services, but this work was kind of thrust upon us due to recent changes in the PSR or provider selection regime regulations, which means that we need to issue new contract from the local authority or between the local authority and all GP practices for these services. However, we have taken the opportunity to do some engagement with you all over the last year or so and review the long-standing programme arrangements to see whether we could make any possible improvements with this new commissioning round. One thing that you said to us was around the sheer number of contracts that there are within primary care and within GP practices. So we did take the opportunity to work together, particularly between ourselves and our sexual health colleagues, to bring things together into a joint specification and a joint contract, but some key differences in the new approaches that we're proposing for both services. We're hoping that the new contract offers you a little bit more flexibility in terms of being able to accommodate different innovations that you might want to do within your area. And we thankfully have been able to maintain the total program budgets that we have, but we're also very consciously trying to improve the equity of access and outcomes from both programs going forwards. As I say, we've been trying as best as we can since the contract went live, and also before Christmas. Contract, the specification and contract kind of came out, or not the contract, the specifications came out in January. And we've been best as we can trying to go around and engage with most PCNs, and we also put a webinar on last month that hopefully people have been able to catch, that details the changes that have been proposed, but also the process of applying. And as I mentioned earlier, the challenge now, I suppose, is that the initial round of submissions is closing this Friday, and I know there's been lots of activity in terms of people trying to register, but we'll go through that in a little bit more detail as we go. Just to go through a little bit of key points from NHS Health Check side before I hand over to Matt. There's virtually no changes that we're proposing to the actual delivery of an NHS Health Check itself. There's a national protocol for the delivery of health checks, which is pretty much exactly the same for this coming year. What we have done is just introduce some small changes to allow innovation for more efficient delivery. And the main change that people have picked up on or need to be aware of is the changes to the tariff system. So previously we were paying a standard tariff of £18 per check, which has been increased to £20 per check for a low risk health check. But then we're also, rather than just having a high risk tariff for those people that have a health check and end up with a Q risk score of 20 plus, where we would pay a higher fee, essentially. We've introduced an enhanced tariff whereby we can look at our identifiable characteristics through eHealth Scope. So practices can identify those people that they know are current smokers from Black or South Asian groups, or those living in our core 20 most deprived areas, and routinely invite them or try to encourage their participation and them coming forward for their check. And if so, they'll receive £34 per check for those patients coming forward, as well as those that end up being Q risk score 20 plus as well. Some key points, and just to say that hopefully most practices or you'll have picked up that we've sent out packs about looking at modeling the income that you can generate and the type of activity that we're looking to promote through the new contract going forwards. This is all available to you if you've not had it already, but within that there definitely is the opportunity to deliver more cost-effective checks. So using those targeted invites to guaranteed enhanced tariff patients. So we have modelled that there's roughly about 11 times more patients that will fall into that new enhanced criteria due to the changes that we've made than you would get through the current high-risk outcome criteria. The compromise that we've had to make within the existing programme budget is obviously we have to accept that there might well be less activity on health checks overall, but there's potential to deliver less checks but receive higher payments for these checks under the new spec, and that will hopefully result in an increased average cost per check over time to practices. The third point there, so even if we're delivering health checks using the existing engagement methods, so if practices just carry on doing exactly what they're doing now, so they don't shift towards that more targeted use of the health scope risk stratification tool, the vast majority of practices would generate more income over the new specification if we look at the previous 5 years activity, just because a lot of patients that come through that you're already inviting routinely do meet some of those other enhanced criteria already. There's a lot more flexibility in the new spec to deliver the checks innovatively, and we'd be looking to support practices trying to do that either within a PCN area or thinking about how they can use community spaces, etc., to try and improve access and uptake of health checks and improve their cost effectiveness. By introducing these enhanced tariffs and those characteristics, it's going to make it a little bit easier for that targeted engagement approach, and that will hopefully improve that equity of access and outcomes as well. And then lastly, alongside the implementation of the new contract, we'll be developing a practitioner training program and introducing new outcome monitoring and coordinated information and local resources for you to support patients and bring them forward from next year onwards. Matt, I'll hand over to you now.
Thank you very much. Yeah, I just want to give an overview of the LARC contracts that we're going out at the moment. So in terms of the background, when we've been kind of engaging with GPs and kind of hearing from kind of national kind of reports, we've heard quite a lot of different things. So one of the main ones locally was the complexity of our tariff-based system, that there's 2 tariffs across the county. This is for historical reasons, particularly when Basildor was aligned with South Yorkshire, and also the non-payment in some areas for LARC products, and we've sought to address that as we've gone out to recommission. We've also heard around the complexities in the training to kind of get access to training and also either upskill, train new people, replace new LARC fitters. We've also heard a lot about the cost effectiveness and viability of the LARC service to kind of do this in your practice. And then finally, we've also kind of heard about the issues around a lot of the bureaucracy that we create, either in kind of sending us information around your kind of qualifications and accreditation, and also the backwards and forwards of spreadsheets to pay you, and we've addressed that as well. So I just want to go over today the change to the tariffs and then introduce the training incentive. Next slide, thank you. So that is just an overview of what was talking about the complexity in the tariff structure, in that we had one tariff across mid knots and south knots, and then we had one in Basildor as well. And what we've done is we've introduced a new structure across the whole of Nottinghamshire. That means it includes Basildor as well. We've also introduced, as a result of feedback, a coil replacement fee, and also which is quite new for local authorities, is introducing a kind of failed fit or a failed procedure fee as well. Okay, next slide, please. It's a little bit small, and more detail will be given around the training incentive, but in short, we've used kind of our budgets based on kind of feedback as well to fund up to 20 new LARC fitters per year across 3 years. And what we mean by funding, this means that obviously you'll get your training free through our new sexual health service, which started in October. But you will get your letters of competency paid for, 1 attempt on the online theory assessment, and then 1 year membership of the faculty there. We're just finalising some of the criteria for that, but this is a draft LARC training pathway, which I'm just finalising with our sexual health service. But we will be where we've got either kind of high demand or we've got a lack of fitters in there. And with when the new contract is issued, more detail will be issued for how to apply for this funding. We've had quite a few questions. It looks as though it's been quite popular. This is not necessarily just for GPs. This is for practice nurses and other kind of qualified staff as well. Next slide, please. Some other benefits that we think with this new contract, and this goes for LARC for health checks as well. We've shifted across to a NHS kind of contract instead of a local authority contract, so it should be kind of terms and conditions that you're familiar with. One big development is a transition towards eHealth scope for invoicing for LARC. So this will reduce the need to send spreadsheets to us with all your activity. We will automatically go into eHealth scope to extract that. That won't start from April. We've just got a GP doing some coding work and testing work for us, but that will go live in the immediate future. We're aligning our payments together, so both LARC and health checks will be done on a monthly basis, and we've reduced the need to send in evidence of your letters of competency and other accreditation to us. By signing up to the contract, you will be agreeing that you've got those in place. And also as well for our Bassett Law kind of colleagues, we will be reimbursing all LARC products as we kind of currently do in the rest of the county. Next slide, please. So importantly, the next steps, as Paul kind of outlined, we've got a lot of kind of comms out there. If you want to apply, which we hope that you do, this must be all done through East Midlands tender. I've sent out numerous kind of communications to practice managers and on TeamNet, of which there is a guide of how to do that. But please do, if you have any kind of questions or difficulties, please do contact myself or Darren, but me in particular, because we can escalate those internally within our procurement team through to East Midlands tender. That has worked well in the past. Just want to spend a little bit of time on the deadline. So the initial round for submissions will close on the 7th of March. That will then give us time to issue kind of contracts ready for an April start. If you don't get your submissions in, what that will mean is then from April we will issue kind of a contract notice, so you'll still be able to kind of continue services for the next 3 months. But what will happen though is a new round will open, and then you can apply for that, but that won't start till July. So it will cause some difficulties for us in terms of there will be kind of 2 tariffs for both kind of contracts, but from July there'll just be 1 contract, and we'll start with this contract that we're kind of starting for practices that have signed up from April. I would really advise that if you haven't started your application, that you do start it now, mainly because when you do register, it can take 1 or 2 days for all your registration details to come back and get your registration to fill it in. And again, any more difficulties, the information guides that is attached to the email and to TeamNet will help, but if not, please do contact me. And then just finally, as Paul's kind of echoed for LARC, we are very keen to look at kind of alternative models, particularly around kind of coming together to do into practice referral schemes. We'll have a few chats with some GPs that are interested in that in the future. Thank you very much.
Excellent. Thank you very much, Matt. Is there anything else to add, Paul?
No, thank you. No, I think that's it. Yeah, just if there's any queries or questions, but
you're
yeah,
in luck. It's a Monday. There's plenty of questions. So what I'll do is I'll just quickly go through those if that's okay, and then we'll come back. Okay, Dr. James Hopkinson from the Capital Practice said maintaining the budget does not fit with inflationary national insurance minimum wage and 3% background inflation, conservative estimates for health costs for practices. What is the plan if practices don't sign up?
Yeah, I think maintaining the budget our end is a result. That's something that we're quite proud that we've actually managed to achieve, because obviously the local authority budget and the public health budget is stretched. So we've been quite reassured on the one hand that we've within the LARC services and within NHS Health Checks, we have actually managed to maintain that total program budget, because other services have been kind of effective as money gets a little bit tighter. So I think the decisions that we've made is trying to make the best with the budget that we do have, particularly from an NHS Health Checks point of view. It's kind of getting that compromise between being able to reward for the activity as best we can, whilst thinking about the equity of access to health checks and how we can improve population health outcomes in a proportionate way, I suppose, based on needs. So absolutely taking into account all of those things. And when we started out on this process, we wouldn't have necessarily known about all of the inflation, etc. That's something that we will keep an eye on going forward as we kind of review the contracts year on year. And we've hopefully taken that into account with a move towards those enhanced tariff checks to make sure that more of our NHS health checks can be more rewarding for practices to take some of those things in. At the moment, there isn't a plan per se for those practices that don't sign up. We're very much working on the basis that our preferred option is that all practices sign up to deliver health checks as they are now. And then as we move forward, if it's very much looking like there are some practices that aren't signing up, then we will have to explore different types of provision to make sure that we can kind of meet that mandatory requirement that we have from a county council point of view to ensure that all those eligible residents can have their health checks somewhere. But at the moment, yeah, there's no detailed plan to support that.
Okay, thank you, Paul. We'll go to James and then we'll go to Debbie. James?
Yeah, just follow up on that. I suppose the point is that if it costs more money to deliver a health check than it does in the remuneration, practice are small businesses and they'll just not do it and not sign up, which means that the county council therefore isn't fulfilling its statutory responsibilities, and that is a real risk here, because the fact that we've done. I totally agree with you. In this climate, maintaining a budget is a really good thing, and it's quite impressive. At the same time, this is a simple business transaction statement, and if it doesn't pay more than it costs, people won't do it. And in particular, the enhanced tariff. The whole point of the enhanced tariff is we're more likely to find people with things that need work doing.
Yeah.
And that's a good thing for health, but it's a bad thing for cost. And although I approve of those people being targeted with a higher fee, I'm not convinced that it covers the costs. And I certainly think if this is an ongoing process where year on year is that we have a flat budget, then at some point, I wouldn't be surprised if we get a very significant number of practices that just go, this isn't cost effective for us anymore.
Yeah.
So your plan B may need to be considered beforehand, or at least anyway, because I think we've got a lot of questions in terms of what if will be from those practices where the patients are affected and they haven't signed up to, the contract on offer today. Debbie, you got your hand up?
Yeah, so it's the bit that's concerning us is we've got to decide quite quick if we're going to do it or not. And when we've been working out with our nurse capacity and everything else, we're thinking we might only be able to do it at scale. So, but it's saying that there's a cap of 20%. It says threshold of only 20% of eligible 5-year population invited per year. So does that mean we can't do more than 20% in a year? Or what does that mean? Could you please explain that 20% threshold?
Well, yeah, it's basically over a 5-year period, the practices should be aiming to get 100% of those eligible patients to come forward for their health check. So
what if we did that? So if we did that over a year, would we not get paid? Is that a cap of 20%, or are we free to do, say, 50% in a year?
Yeah, I think because we're introducing this new system, we're going to have to monitor the budgets and the finances really
But the
really
problem
carefully.
is, Paul. But the problem
Yeah.
is, Paul, with that, I've got to recruit potentially. So if you then say to me halfway through the year you're doing too many, I'm scuppered, aren't I?
Potentially, yeah, potentially if everyone was doing
Okay,
the same.
so when you're pulling up these big numbers for practices to make a decision on, like you could earn £100,000, I think it was for us, or whatever it was, it doesn't actually quite pan out like that over a year, because I see what you're saying about, you know, the more at-risk population, but I know as soon as I advertise this, I'm going to get all the worried well coming forward that's been waiting for us to start doing these health checks again. So I could soon get into my 20% of patients who are only going to earn me £20 and not the £34. It's going to, or whatever it is, it's going to take a lot more work getting those of us to come in. And so if I'm then capped at 20%, and if other practices, you know, are thinking doing this on a PCN level or on an scale level, is that fully understood by everybody, that there is a potential that you can only do 20% of your population? And is that 20% of invites, because it says invited per year, not completed per year? So I might need to invite 50% of my population to get 20%. So I think that needs real clarification, because that can make a difference literally this week of whether I sign up or not. Because, you know, I might, if I need to put some more staff into this, I don't want to commit to them staff if I'm only restricted to earning. I've worked out I can only earn between 20 and 30 grand a year. So the cost, once you start adding that in, if I need more people to do it, soon mounts up. And my other point is, I think if people do score over 20%, you still have to see them face to face, it says. If you've got a Q-risk score of over 20% or an at-risk over 20%, it says that we still have to see them face to face. Is that still standing in the spec?
It's a second appointment, isn't it? So yeah, as written in the spec, but it wouldn't necessarily have to be face to face. I think
so again, at what point, if we choose not to do it, I've broken it down into 5 steps. So okay, so the first step is we identify patients. The second step, we invite them. Okay, we then conduct the health check, as in bloods, everything else. We then communicate. So step 4 is communicating their results to them. And it said if they're over 20%, you have to see them face to face and do all lifestyle intervention and statins and stuff like that. So if it went to somebody else, I'm presuming under this screening spec, they do it up to step 4, and then they're referred back to us in step 5 for follow-up and referral if they're added to our CVD register. So if we choose not to do it, I'm presuming under this spec, it goes right to communicate risk and provide advice by the other provider who does the spec. And I think that needs clarifying, because what we don't want to do is say no to this spec and then everybody come back to us after step 3 and not after step 4.
Okay.
So if we can clarify for me the 20%, because that is, you know, I think a lot of people are planning to do it at scale, because it's the only way you can kind of maybe make it cost effective. I don't know what others think about that. And the other point is, at what step, if we choose not to do it, do we kick in? Because is it that much risk to us having another provider doing it? Because the likelihood is that they may not get all the at-risk patients anyway, because they won't come to another provider. You know, there's loads. I'm not worried. I'm not threatened by other providers, if I'm honest. Not in Newark. So that's my point really. And obviously that face-to-face bit, because we do a lot of telephone consultations and things now. So that's changed that a little bit.
Yeah.
Okay, so that's me done.
Cool, thank you, Debbie. So question from Carly from Trentside. How do you know which areas are the core 20 areas, please? I think this is
just-
LARC, wasn't it?
Yeah. Oh no, it's more for the NHS health checks again, this one. So that's by postcode, basically. So yeah, there'll be a risk stratified list of patients within eHealth Scope as there is now. But there'll be a new list, obviously, with the enhanced criteria and those target cohorts, and that will include those people from core 20 or most deprived postcodes.
Okay, thank you, Paul. Debbie Swain put in, please could you explain the 20% cap?
I've already
invite-
done that.
Yeah.
Yeah, I've already done that, Stuart.
Dr. Hussein Mauji from Victoria Mapley, is this approach going to be mirrored in City, commissioned by City Council?
Not as far as we are aware. I think they've got existing arrangements in the city, and I believe that they're due to recommission at some point next year. But
Yeah.
you would have to check with the city commissioners on that one for NHS health checks. Matt, I don't know if there's anything on LARC in the city that you're aware of.
Yeah, again, I don't want to say too much, but I know they are going through the approvals process to address their kind of funding at the moment. So yeah, I don't want to kind of say because it's still being discussed at the moment.
Okay. So there's potential to watch what happens in county. Claire Booth from Sherwood Medical Partnership, is there a failed removal fee as well as a failed fit?
Okay, yep. So this is a little bit where we've just had to take advice from clinicians really, but in terms of the failed fit for a coil, I think it's pretty obvious that it's a failed fit. What we've had to kind of take advice is, we originally called it a failed implant fit, but we've just called it a failed procedure. So anywhere where you've tried to make an attempt and for whatever reason, if it's failed and you didn't do it, you've had the session, you didn't do it, that's when you then apply the tariff. I think there's some misunderstanding, I think, from our part, particularly around the implant. So I think it's just terminology, but anywhere where someone's turned up for an appointment, you've not been able to carry that out. It's not a DNA, but it's a, where you've just not been able to carry out that procedure.
Okay, thank you. Dr. Hussein Ali from Jackson Medical Centre, can you please clarify regarding the discrepancy in fees between replacing versus removal and insertion? What is stopping practice from coding as insertion and removal? I think you may mean from that.
Yep. So one of the things that we will be providing guidance on when we move to eHealth Scope is the coding to allow to get paid. So at the moment we've got dual language working on that, where she's tracking the coding across our specs. That's still being worked on between Jill and the eHealth Scope team.
Okay. Thank you very much. Dr. Hussein Mauji again. Matt, as you're aware, a GP fellow last year focused on increasing LARC's training and capacity, but there was structural issues with enabling our hospital clinics to provide the necessary honorary contracts for primary care clinicians to do their sessions in the sexual health clinics. Has this been overcome, and is public health able to support overcoming this as part of the training offer?
Yep, thank you very much. Now, it's something that we are aware of. It doesn't appear to be a simple solution, particularly with NUH being our lead provider. But we are just at the moment kind of finalising our training plan with NUH, because it is a KPI of their contract. So we'll be expecting that to be on to find either simplification of the process, maybe in terms of guidance, or whether we can do something novel. Because we are in contract with Sherwood Forest Hospital Trust as well. But yes, thank you. We are aware of it, and we will try and address that. But at the moment, there's not a simple solution.
Okay, thank you, Matt. Watch this space. Claire Booth from Sherwood Medical Partnership. Would we be able to send in amendments for the payments if the data extracted from eHealth Scope doesn't match our activity on System 1?
Yep, that's no problem. We are we'll be doing some testing of that. So dual language will be kind of asking maybe a couple of practices to test that to see how accurate it is based on the codes that we provide. But no, I think having a fail-safe kind of procedure will be good. Thank you for that suggestion.
Okay, thank you very much, Andrew. WinCup at East Bridgford Medical Centre. It will be difficult to meet the deadline, as in this Friday, when there are issues registering on the website, and their support takes 5 days to get back to you. So I don't know if you're aware of this.
Yep, now been supporting a lot of GP practices. As I would kind of suggest, and I think he has, is to contact us because we can escalate internally. We have our own kind of procedure as a buyer of this service. As I kind of mentioned before, this is not like the opportunity though it's just going to close, it's never going to open again. So it will open again pretty soon. You'll be on the existing kind of tariffs up until July, and then we can then start again on the new contract. But we will be issuing a contract notice from April, but that gives 3 months notice. So don't worry too much on that.
Okay, thank you. And I see that you've replied afterwards anyway. Alison Bailey said she signed up and completed it all on Friday afternoon. Was very straightforward, but the guidance is a godsend. Dr. James Hopkinson from Calverton Practice said you can do more than 20% in a year, you just won't be paid. Okay, and Andrew's come back saying he's still getting errors when he's logging in. And Dr. James Reed from the Manor Surgery do agree, seems odd that 20% invite. So obviously working at scale. I don't know whether you want to come back to any of those things I've just quickly whizzed through.
Yeah, I mean, I don't think any of those things are set in stone because we're just going to have to monitor the budget and activity for health checks particularly very closely. Very few, if any, of our practices actually meet that deliver health checks to 20% of their eligible population on a yearly basis anyway. Because as I say, it's dependent on everyone actually turning up for it. So if practices were wanting to move to an at-scale model, that's not been done before. But you know, we would just have to work with practices to find a way forward.
So during all this process, because I know I've been involved and Debbie Swain's been involved and some other PM colleagues as well over the last 17 months, where we talked about, and I know there's a practice in Basildor who has their own PCN, and they were involved in working at scale. And I think there was going to be an opportunity of maybe presenting that case study to try and learn a bit more as to how they did that. And I know they did significant amount of numbers within a particular amount of time. So obviously we're now looking at 20%. It'd be really interesting to maybe we talk about innovation, whether that practice and that case study could be shared wider across across Nottinghamshire.
Yeah, I think that's included. I just didn't present that slide today, but it's been included in the presentation pack that's gone out via all PCNs.
Okay.
So it is available and can talk to it. Yeah, it was a really, really good case study, but I mean, reflective of the fact that there's been quite a lot of underspend over the years on NHS health checks anyway. So we've been able to support Newgate practice that was to do something innovative in that space. But as I say, there was lots of learning from that can be shared in terms of how to make things more cost effective, but also involving the whole team in the process of the pathway, including the patient. So yeah.
Okay, thank you. Debbie, got your hand up?
Yeah, I think this is where it kind of falls down a little bit for us, Paul, because I feel like, there's been these nice presentations with, big numbers, and, we've had people bang on quite a lot about the Bassett Law 1, which is exactly what I was coming to, Stuart. But then in reality, when we're all due to sign the dotted line, we could well be restricted. And I don't think you can look on what's been done in the past. Because for example, we have literally just parked NHS health checks because we've neither had the capacity nor did we think it was worthwhile. Yeah. So we're bound to have underspends. And actually, when I spoke to I think it was Jill quite a while ago, the budget that the council had was a lot more than what it is now, because it has been underspent over the years. Yeah. So they've reduced it year on year, and that's why we're in the situation we're in now, because practices have kind of thought, oh, well, it's not worth a while chasing or doing, that's resulted in less of an allocation now with you guys to us, when actually now we might be saying, well, we'll look at it again because, the money's not gone up, it's not that great, but now we're restricted to do it at scale, when actually that's where we could make the money doing it at scale. So I feel a bit like we've been shown big numbers on presentations, which made everybody's eyes possibly pop out the head, and we've been shown this Bassett law model, but actually in reality we may not be able to do either, earn that much or do the at scale model. And then if we all don't sign up, some other private enterprise or whatever, or a PCN or federation could trot along and go to you, well, we'll do it at scale, and you're going to go, well, okay then, because nobody else is doing it and we're underspent, and then the cycle goes on. That's my piece said, really.
At the end of the day, though, Debbie, I would absolutely love to go back to our director and say, hang on, there's a big risk here in terms of the activity that we've got now coming through health checks with this new contract and our ability to actually pay for all the activity. I would love to have that conversation. I don't know whether we will get there, but obviously we've just had to be cautious in terms of how we've worded things within the contract to make sure that we can afford things in the short term. I'm not saying that there's lots of money there that would be able to supplement that budget, but at the same time, it'd be fantastic if we were really kind of maxing out across the board. So I'd certainly encourage practices to do as much as they can within what we've suggested. As I say, this was always going to be a compromise at the moment. So
I'm just concerned that people may, and I don't know if there's anybody on this talk that may have been planning to do it through a PCN at scale and now might be thinking, oh gosh, I didn't realise that 20%. So I just wanted that out there and clear, really. Just in case people are planning to do it like the Bassett law one at scale, that it might not get paid for it. So okay.
But as I understand it, I think the Bassett law, they invited more than 20%, but
exactly.
over the course of the year they still didn't do more than 20% in terms of activity and uptake. So
yeah, because 20% for us is only, I think it's about 19 health checks a year if you're working on the 75%. Yeah, it's not that much. It's only 1,000 a year, and if you spread that over your months, it's not that many a month. But it's just fitting it in with the SDS and dressings and everything else.
It is, and I think at the moment it's the unknown aspects in terms of, and I know you don't know this at the moment, Paul, but those who practices which don't sign up to this, and then there's questions in terms of from practices to say what happens with our patients, where do we do it, what do we do in terms of reassurance about information governance and data sharing. Then we also have in terms of the clinical monitoring of those patients and anything that's identified, who now manages those things, because no doubt it probably is there going to be a workload transfer back to practices who are the originators of those patients. And these are the sorts of things where practices probably at the moment are sitting there with a spec thinking, where do we go? We could sign up to this, but we've got probably more questions than we have answers. And then the second part will be the what if, and where do we fit in all of this? So, but
I think
during the whole
Stuart,
journey,
sorry, Stuart, it's been absolutely clear and transparent, isn't it, about what we're signing up to? Because again, I'm still not, I think I've spoken to quite a few people, and their thinking is that if somebody else does it, we're going to get all the blood results and everything else to act on, and that's not quite how I'm reading the spec. I'm reading the spec that we only get them back at the point that they are diagnosed with something, and they go on to our CVD register. That's at the point we should get them back. But again, I'm not clear on that. And I don't think you'll get that many back that hit your register either, because I just don't think you will. Even though you've identified people, I just still don't think it'll be those coming through. So like I said with the steps, and I can share this with you, Stuart, but it's at what step it comes back to us, because I think, like I say, a lot of practices think it's going to come back to us as soon as the bloods are taken. We're going to get all the blood results. And then we've got to do the Q risk, and we've got to act on that, but that's not quite what it's saying.
Yeah. Okay. Obviously, there's been some questions in the chat in terms of practice signing up and penalties, etc., for which Matthew has kindly answered. So I do appreciate that as well. And I'm just wondering, are there any other questions at all from practices? Because I'm just about to hand over to Lucy, if that's okay. No. Okay. No. Obviously, we have your details anyway, don't we, Paul and Matthew? So practice to have that. So if there are any questions following this, feel free to contact the team at the Notts County Council and hopefully steer you in the right direction and give you help. But I think the FAQ as well, Matthew, that the support you've given to practice has been really good. So thank you for that. Lovely to have you both along today, and hopefully be in contact. Please stay in contact anyway throughout the next couple of weeks, and it'll be interesting to see how things kind of go. But yeah, lovely. Thanks for coming along to today.
Yeah.
Thank you.
Thank you. Bye.
Cheers all.
Okay, I'll hand over to Lucy if that's okay.
Thanks, Stu. So up next, we've got Dr. Kelvin Lim and Sudhakar Shinde, who are going to be talking about COVID and flu vaccination programme.
Hi, thanks, Lucy. Thanks for the invitation. We came a little while ago and we talked about how the vaccination programme was going, and we took away some thematic things. We've got also Debbie Stiles-Powell, who's in the meeting today, I believe. I wonder whether the presentation should be done by Debbie or Sunika. Do you want to go ahead, please? I think they're on the call.
Yeah, I think, without any delay, I'm conscious about time as well. Yeah, Debbie, would you mind to share the slides and run through, please? Thank you.
Yep, we'll try and run through this in the 10 minutes we've got left. Right, basically, this is going to be a review of how flu and COVID went in autumn winter 24, and then some points of learning that we've intended to take forward to see how we can improve uptake going forward. And there'll be a little bit about answering some of the questions that have been raised when we've been engaging with PCNs and the LMC over the last few months around flu. So in terms of flu, uptake was 53% this year. That's 3% up on last year, mostly driven by school-age children. So primary school was 12% up and secondary school 11% up. Our elderly population, at-risk population, was 2% lower. The school-age children isn't much to get excited about because actually our performance was quite bad last year. And for 2 to 3 year olds, even though we did that jiggle around, so we started with 2 to 3 year olds from the 1st of September and then adults from October, the uptake was the same. So basically you just saw everyone earlier. For COVID, uptake was 43%. That's 2% lower than last year. But our over 75 population was something like 10%, over 65 population was something like 10% down. Again, that's a concern. I don't know how much of this is vaccine fatigue, because obviously we're just about to go into another spring campaign, and I don't know how many people are getting fed up with having needles stuck in their arms. So if we look at each of the age ranges, for flu, as the uptake was 42%. We're having this ongoing theme around variations between place, and the variation between south and city. In each of these cohorts, that number is getting more and more significant as we go through each of the programmes. For flu, again, uptake 77%, 11% variation between south and city. But the interesting thing with flu is if you look at the age of the people that are uptaking, we seem to have lower uptake in our younger population, so our 65 to 69 year olds. It's something that's worth looking in, something that's worth me looking into as a commissioner, because obviously these people haven't necessarily been vaccinated since they had their routine vaccinations as a child. And I think there's probably a bit more we can do about actually promoting that. For at-risk population, our uptake was 45%. And I've added in something at the bottom around each of the conditions. So interestingly, I think it's less than 50% of our people with chronic respiratory conditions that are coming forward, which does sound a bit strange considering those are the people that are more likely to have complications and be admitted if they get flu. And there are some other conditions there that we'd like to work on. The one I think we're going to struggle with is the morbidly obese, because obviously that's involving having conversations with patients about their weight. And we know we struggle with that on some occasions. For pregnant ladies, there's a 16% variation between South and City and Basset law. Again, we're looking to how we can work with maternity services to see how we can improve uptake. There are some things I know are happening in NUH, like them sending text reminders to maternity pregnant ladies to say you are eligible for this vaccination. Some bits that you came up with as we've been going through this: vaccine ordering and supply. Understand that the orders have to be made ridiculously early. Understand that unused supplies waste and cost of the practice. So we're almost into this vicious circle where you reduce your order the following year to reduce your waste. Couple of bits on this: if you're within a PCN that has a collaborative agreement, you can share your vaccine, so you can sort of pull together and have a PCN clinic as opposed to an individual practice clinic. You can't sell on spare vaccines, it's not part of the legal arrangements for flu. But what I will be doing in terms of this risk around reducing orders is I will be reviewing all practice orders in March to establish the level of supply across the system compared with the eligible population. There was a lot of conversations about the guidance was issued late, you'd started clinic planning, and obviously the guidance shifted the start date for flu into the start of October. There was actually a letter that came out on the 30th of May that did indicate that it would be early October, but I do agree the actual letter confirming the date wasn't actually issued until August. On the plus side, we have the flu and COVID letters this year. So we know we're not vaccinating in September, but we still have an issue with the exact date of the October start. Other issues people raised: practices can't offer walk-ins in the same way that other providers can. Yes, but practices can offer opportunistic vaccines where people turn up to the practice for something else. And actually, if I look at the vaccination activity, we are still getting a steady stream of people being vaccinated against flu in practices. There were some questions about school-aged children mop-up. Practices aren't commissioned to vaccinate healthy school-aged children. I have my own view on that, because I think it's really inconvenient for people if they've missed their school. They would naturally want to go to their GP to be vaccinated. They can't. But what we're planning to do is work with School Age Immunisation Service to improve the out-of-school offer. Two things on that: investigating actually doing additional clinics and not necessarily isolating them to half-term holidays, but also looking at how early we plan those clinics. My feeling for autumn was they were planned quite late, and then getting comms out so people do know if they missed their school vaccination, they can go to other clinics. The other thorny issue was vaccination of practice staff.
Talking about
yes, you can vaccinate.
smears and
Oh, sorry,
variations
someone's just talking, Debbie, at the moment that isn't
Flu.
on mute. Just bear with me. Yeah, sorry.
Sorry, just got confused then. Practice can vaccinate their own staff, but it's considered an occupational offer, so you're not reimbursed for the vaccine costs, and you don't get an item of service payment. Again, this is a contractual thing, and we have been pushing back to the national team around whether that is actually fair or appropriate for GP practices. Obviously, from a health point of view, it makes more sense to vaccinate your people, your staff, because obviously then you're protecting them against flu, whilst they're dealing with very sick people. As I said, JCVI guidance has been issued for both COVID and flu. For flu, it's the same model as this year. So from the 1st of September, it's children and pregnant ladies. And then from October, annoyingly exact date to be confirmed, and I did have one practice feedback to me, they'd seen the October date, so actually planned the clinic for the 1st of October, which was then quite obviously stymied by us starting on the 3rd of October. And the eligibility criteria are the same for next autumn as they are for this autumn. Things we're going to look at, and I think I've alluded to some of these: do we need to have some specific work focusing on 65 to 69-year-olds? As I said, they haven't been routinely vaccinated since childhood. The other thing is the last time these people were called for vaccinations was during COVID, when we dropped down through the age ranges and flu was at 50+. There may be some more hesitancy around there. And then for at-risk citizens, do we need to target specific conditions, be more targeted in our comms, just looking at certain conditions? We've used the mobile unit in the past, but I can never guarantee that that areas of low uptake actually come to those units. There are a lot of groups in city and county that I think we should be working on who actually are sort of support groups for people with certain conditions. And I think there's something more around what we can do with the social prescribers and the community champions. And I managed to do that within record time.
Thank you, Debbie. That was very impressive. There's 2 minutes to go. We certainly welcome you all back at a later date if there's anything that you feel that's been missed, or if practices feel that they have any further questions. There's bits in the chat just perhaps to reflect on after. So just talking about the midwives, there's a sort of general feeling from colleagues that some of the midwives aren't proactively sort of asking about flu. People are asking about why they can't give, why the midwives can't give the flu vaccinations. Again, sounds like too much like common sense, unfortunately. Yeah, Tudor has just said midwife. Oh, sorry, doctor. Apparently midwives told one of our patients it was too late. So there's definitely some themes coming up here about the works of the trust and the conversations that the midwives are having with patients. And Jen, I can see you've got your hand up. Did you want to come in?
Yeah, I just wanted to remind Debbie that there was a whole load of work that we did over COVID, which actually was about educating midwives. It might be worth dusting off some of that about helping promote midwives to help promote vaccination there. So it already exists. There's video training that we did, and at that time we made it mandatory. So
thank you. Yeah, I think I was aware of that. We could probably link that into some public health funding we've got around education of healthcare workers and people who actually have contacts.
Well, so this was done in combination with the health visitors, using training people how to use active listening and nice ways of trying to persuade vaccine hesitant people how to train. So it might be worth just getting that out. I'm trying to think who might have access to it, but I'll leave that with you. I don't have it. Don't ask me.
I won't.
Thanks, Jen. There's also lots in the chat about practices needing to be aware of how much they're ordering. Reflecting on last year, there was a lot of wastage, a lot of loss of income. Debbie, other practice managers are saying that they've reduced theirs as well. Kelvin, this is a question to you really, and apologies for putting you on the spot, but I'm going to. So last week we had Paul Miller from the ICB IT team talk to us about the potential loss or change in budget to text messaging for practices, and a suggestion made to cap at 0.3% of the patient list, or I'm getting the numbers wrong, but there's a cap that's suggested. Obviously, we want patients to be vaccinated, and one way to do that is to continue to text them. If the ICB put a cap on text messaging, what will that mean for flu and COVID uptake, do you think? And can you support us in challenging this decision, please?
No, absolutely right. I think it seems to be an incongruous decision to make, especially when practices are heavily dependent on text purposes, and also we've been pushed towards more digital and more communication with patients. It seems incongruous to do that. We have pushed back to Stephen Short, for example, to argue the case. There is a meeting at the One Voice Forum next week, where any of the GPs are able to should attend, where we're pushing back again towards that. I believe the LMC are making representations too. It doesn't seem correct, and it will affect vaccinations and immunizations, I've no doubt. So that's why we are pushing back against that, and we hope to win this one. I think that there are quite a few people who are against that, if that's helpful.
Yeah. Thanks, Calvin, that is helpful, and thank you, James. So James Hopkinson, our LMC medical director, and myself are meeting with Paul tomorrow. As you've said, it's 3 pence per patient per month with the suggested capping. And I think it's just important that with this, we do talk as a one voice system, that if we want to see an increase in uptake for flu and COVID and whooping cough and everything else, that common sense again hopefully prevails with the cap. Debbie?
Lucy, just a quick one. While you're having a chat to them, it was a bit strange, the list that they gave us, where I think Kate Hunter maybe asked them what, or somebody asked them what was included in the budget. So what could we lose again?
Yeah.
And it was a bit strange that things like PAF links, you know, we can't do without PAF links. So why is that affected in our budget? It was just things like that, really.
Yeah, so I've asked Paul, we are meeting him tomorrow. He's going to provide us with a full breakdown of the primary care IT budget and what it's allocated against, just so that we get an idea of, you know, if we've got X amount for this and this is everything that we pay for, what does that mean? And then we'll feedback next week when we know a little bit more. Lisa?
Hi. Oh, sorry, my camera's not working. Just a little one. I think it's just really frustrating. Every year we get rid of every flu vaccination in our practice. This year we have half about under 65s left. I've got so many that we're just going to lose so much money on, and I'm really reluctant right now this minute to put the final order in. I'm really holding back, hoping that somebody's just going to say, this has changed. No, we're not going to do this. Oh, we're going to do this, because I'm just so apprehensive. There's so many vaccinations out there at the moment. Personally, I know what's with the midwives. My daughter's got a 12-month-old. She's pregnant again. But she's been to the midwife. She's not been told to have any vaccinations. I've said, well, are you having the RSV vaccination? Now you're 28 weeks. I don't know anything about it. Nobody's told her about it. The fact that we order RSV vaccinations, it's the same vaccination that comes, but we have to give the different batch numbers to the different pregnant ladies, to the different over 75s. So the fact that they brought out the RSV vaccinations 2 weeks before the flu campaign went live, and we couldn't give them within 2 weeks of having flu. Patients are fed up of all these vaccinations, Pneumovax, RSV, COVID, flu. I think the patients have given up. We've sent text messages out, we've telephoned patients, we've sent letters, we've put it on Facebook, we've put it on our website. I don't know what more we can do. Sorry, ranted.
Lucy, as well, we got an email through our PCN as well from the ICB saying they've got some funding, and did we want a bus to go around the town? You know, and I just thought that's quite rude, really, because we were flipping hard to try and get these people in, and I don't think it makes a difference. They could put a bus right outside of Asda, and I don't think people would go in it. And I just thought, well, that's a waste of money.
Thanks, Debbie. Thanks, Lisa, for sharing. I'm conscious of time. Calvin or Debbie, is there any, or is there anything that you'd like to come back in response to that, having heard from the practices?
Yeah, can I just come back and we fully understand that the business model isn't a good model, and so we need to carry on looking at that. However, we're constrained by national guidelines rather than local guidelines. I think the other thing is that we're you know, we still need to push for vaccinations despite all the business models, because actually we know it's good for our health population, and actually we are working in health. And the third thing I would say is if you have the bus is just one idea. If you have any other ideas in the hard to reach groups, any communities that you can come up with that you would like to share with us, we'd be grateful that if you would share it with us, because we'd like to look at it and explore them.
Thanks,
So,
Calvin.
Thank you.
Thank you. Thanks, Debbie. Thanks, Calvin. Thanks, Sudhakar, for joining. Just before we wrap up, just quickly, we're going to be contacting practices with our position statement. So on Thursday night Friday, you will have seen the notification from GPC England and the BMA regarding the outcome of the national GP contract and the comments about collective actions been paused. we will write to you with more details. That the approach that we're taking is that we cautiously welcome the outcome of the contract negotiations, but like with everything, and Debbie, I know you'll be doing this already, I'm sure, but the devil's in the detail, and it's important to look at the bottom line when you're looking at the figures. So if we think about the changes to the contract overall, it's we're cautiously optimistic about the changes. So I'm just looking down here, so it's going to be 969 million in new investment into general practice. So global sum, it's currently £112.50. In 25-26, it's going to be going up to £121.90. So a per patient uplift of £9.40. However, that does include recycled QOF money. So QOF's being reduced by 71 points. And as always, the devil will be in the detail. So like with the health checks, like with any of the contracts, you need to understand what the impact is going to be from a budget perspective. So have a look at the sums, have a look what it means for you. Safe working hasn't stopped, so it's still really important to work in line with your contract, thinking about 15-minute appointments, capping. Yep, Jen's just said the same as me. So safe working and not doing other uncommissioned work is here to stay. That doesn't change anything. Once we know more, we will share it with you, but we will be sending out a position statement, hopefully by close of play today, with just some initial thoughts on the contract changes and what it means for general practice. Thank you, everybody. We'll leave it there for today, and we look forward to seeing you next week, where Michael Wright, our Chief Executive, and James Hopkinson, our Medical Director, will be giving updates on all things that we're doing behind the scenes at the LMC to support you. Thanks, everybody.